Thank you so much for the introduction and the invitation. It's much appreciated. So to start, I don't have any disclosures at this point. I'm just Canadian. That's my only disclosure.
We're glad you're here.
Yeah. Implicit bias and CLC, competency statements as well, as addressed by Dr. Anderson. So again, from the last three talks, we talked a little about kind of what MCED testing is in terms of being integrated into pancreatic biliary screening, oncology, the general components, how AI can be used to enhance, and then also how we are talking about test performance. My objectives at this point are looking specifically at cost effectiveness in early cancer detection. Is there a component where we're assessing the financial feasibility on a macro and a micro scale, as well as discussing the implementation of different AI, genomics, multi-cancer early detection resources and different technology in either socially vulnerable locations, groups, and or socialized healthcare systems where it's not independent payers. And then also exploring the ethical components of an inherently tiered screening program when we're talking about multi-cancer early detection, in that test is expensive comparatively to other publicly funded programs. So again, in other words, are we looking at an affordable test? Is there a feasibility component? And then in terms of ethical components for introduction of a tiered system. So again, I always like to start also with just a good quote from Sir Gray in terms of whenever you're looking at integrating or starting a new implementation project or a screening program, to acknowledge that there is harm in everything that we do and how we're going to be associating with that harm and how we're going to be addressing it. So in terms of the MCED blood testing and screening tools overall, currently they're being marketed and they're being applicable to asymptomatic populations of average risk. And so this is essentially a number of different multi-cancer detection tools, their relative companies, and then a relative component or comparison between their sensitivities, specificities, and test performance, and then cost to a degree of the ones that are the most applicable. Acknowledging that in this context, we've got a direct comparison between these tests is difficult because of the inherent differences in the validation studies, the pilot studies, how long they were followed, the differences in terms of their true positive and true negatives may change over time, and then the relative cost as well. This is an expensive test that will need to be and will be addressed very frequently in this talk as well. So I couldn't find any real-world clear data studies looking at cost effectiveness in these specific healthcare systems, whether it's North America, Europe, Asian countries. It's just too new. We have a lot of modeling studies, however, that do address this. So there's a number of different modeling studies, some where we're looking at just the USA, some in Canada. There was one recently in 2024 by Lewis. I liked this one, and just for time, we're only going to focus on one of these modeling studies. This is from Hackshaw, specifically looking at is there a component where we're using this as an adjunctive test with existing screening programs as we've currently been discussing, and this is using census data from 2020. There was two very large assumptions just to kind of make us aware of. This is there's an assumption that it's 100% compliance with screening tests, including the MCED testing, and then all downstream investigations, which we knew is a very, very large assumption. And then same thing goes with our diagnostic testing estimates of a one-test diagnostic paradigm, helpful for modeling, but in real life, that doesn't account for multiple diagnostic tests needed. It doesn't account for the hospital costs, resource costs, doctor costs, administrative costs, etc. And so the costs downstream are not captured in this model. So if we start initially looking at the USA-based systems, we've got the light blue bars over here, where we're looking specifically at cancer screening outcomes in terms of what's been detected in the existing programs. The dark blue is in those existing programs, addition of MCED, and then the purple bars are looking specifically at in those programs without, or those organ systems without cancer screening, what does the MCED add to that? So if we look initially when there's no MCED present here, we've got a screening program that has a fair amount of false positives. Its cancer detection rate is quite low, 15%, and then we've got a screening efficacy of 1 in 45. So that means 1 in 43. So that means that for one person to have cancer, 43 people do not have cancer, and all of them had a positive screening test. The diagnostic cost for cancer is almost $90,000 per cancer, and then the overall cost for the screening in a single year is about $16.9 billion. If we add MCED, we notice a significant improvement in the efficacy, 1 to 2, increase in our CDR rate, a decrease in cost to cancer, up down to 7,000 almost, but with an increase in annual costs by about $3 billion. So overall, with the addition of MCED, about kind of a $20 million a year endeavor. If we now look at the UK, more of a socialized healthcare system, the numbers are a little bit different, but the findings are basically the same. With MCED testing, we see an improvement in efficiency, increase in CDR, we've got a decrease in the cost per cancer, and then the cost overall does increase. However, the relative increase is about double compared to that which we saw in the States. So thus it might be a little more difficult for this other type of social model to be implemented. So based on this rough model, could MCED allow for improved cancer detection? Yes. Does it work in cancer groups that don't have existing screening? Also yes. And does it reduce the cost per cancer? Also yes. But actually on the component of, is this a cost-effective strategy? Potentially, but there are significant limitations the authors address and bring forward, which are borne out in all of the modeling studies that have been presented that I won't talk about today. So we're dealing with estimates for screening over a year. Screening is iterative, so it means that we need to acknowledge these costs over time, often with upfront costs, where the benefits of screening are usually something that we've adjusted our cost per quality of life indicator component as a society, as well as acknowledging that the cost savings is something that comes over time. So a lot of the upfront costs need to be acknowledged. In terms of unable to estimate reduction in cancer morbidity, stage shift in general isn't captured in a lot of these initial validation studies and is an ongoing objective in a number of the newer studies that are going on that are more prospective. Oops. In terms of overestimation of cost savings, we're acknowledging that this test was done before a lot of the commercial pricing for different cancer testing technologies was placed. But again, it is one that we can't update, and I will kind of show up a brief calculation soon. And then in terms of the current test performance, as well as the precancerous lesions, there's generally an underestimation of how good the existing screening programs are in those select 4 to 5 cancer groups that we are going to be screening, because of the fact that they can act on precancerous lesions in the sense of reducing the future burden of disease in those patients where they're found. So if we just do some quick back of the napkin calculations in terms of a larger assumption, we've got, let's say, 50% of people over age of 50 are appropriate for asymptomatic screening. If we're using 2024 census data for these 3 specific countries with 3 very different healthcare systems, if we go from the US, let's say our upfront cost for doing a single round of screening in all of these magical people is 60 million times 1,000 for Gallery, and that's $60 billion. In Canada, 11.52 Canadian dollars. Billion, and then in the UK, 10.49. This, again, is kind of Great British Pound, not Euro. So again, that's a very large upfront cost that, again, needs to be balanced with the component of assumed improvement and cost effectiveness later on, as well as a component of adjusting our expectations about how much we're willing to pay for improved quality. Now, to implement a population-level screening test with this baseline cost, likely right now is not feasible, given the current amount of money it would take to start on a population level, as well as the amount of agreement that different parties and agencies would have to essentially find common ground on to make a commitment like this. So in terms of testing on a more individual level, do the people want it, and do they want to pay for it a la carte? So from a survey standpoint, we've got about 70 to 85% of people would be accepting of a blood-based multi-cancer test, in addition to the current screening paradigms within the organ systems that we've already talked about. And again, balanced against that those have screening potential that outweighs the harm of those screening tests. And then when we're looking at the qualitative interviews, so again, smaller studies, but looking more at the qualitative data, people are enthusiastic. There's an enhanced interest for this to be available in primary care, for the discussions, the post-test discussions to also be a discussion within primary care. And then they all endorse very reasonable concerns around cost, risk of false positives, the need for additional screening, and then multi-cancer early detection equity. How is this going to be available to different groups and different populations? So again, willingness to pay is a really important concept to acknowledge in this a la carte model, in that how much money are we willing to pay for a screening intervention or any healthcare intervention. This is a nice systematic review that looks at willingness to pay studies across many different periods of time where our health and our screening has changed significantly. So looking at some of the breakdown in this group of USA, Canadian, and then UK studies, there's a lot of heterogeneity, but what is common is that the factors that influence someone's willingness to pay are socioeconomic status, sex, ethnicity, family history, and then someone's personal history of risk. So someone in Germany who's had melanoma may be more interested in paying thousands of dollars for a cancer prevention test compared to a healthy 20-year-old person in Canada who's never had a cancer at all. That willingness to pay is a very dynamic and individual concept. So if we look specifically within the mean willingness to pay amounts, the most common is less than $500. So already we're kind of settling down to what people can realistically afford and what they're willing to pay on an average component. In the USA, more likely to pay, likely just out of the structure of the system. People are used to paying and it's more of an accepted paradigm, more so than the UK, and which is more so in Canada in general. Knowing here that, again, the only study that looked at willingness to pay threshold was within cervical cancer screening. So outside of financial feasibility, what are barriers that we need to address to implement any of these technologies, whether it's multi-cancer early detection, whether it's a stool-based screening test, cancer genomics, any of these things, on a population level specifically? So again, the expectation of barriers includes that we need to have adequate test performance in a real-world setting, which is currently ongoing in other ongoing studies, but we don't have it yet. We have the test performance components. We don't have integration into a screening program performance, as well as how that would perform in a longer component, where those true positives and true negatives may settle out over time. In terms of the results changing patient management, again, we don't have stage shift information. We don't have concrete information on how much and to what degree this will improve cancer outcomes, cancer costs overall. And then individual or population level, again, we're aiming for population level improvements. Positioning. Integration into the current patient care pathways, will they replace and act as a gatekeeper test? Or is this going to be a pure supplemental test to existing programs? Or are we accepting of the sensitivity in its current form that, as we've kind of mentioned before, is any test better than no test? Acknowledging that the components of false positive and false negative do have real harms. And then choosing the right population. Right now we're advocating and marketing towards average risk population between 50 and 75, acknowledging that is this the right population to be using this test? Should a higher population be targeted? Should someone with family history, should a hereditary cancer predisposition syndrome, is this where this test could shine in the future? More so, however, I do understand why this test was marketed towards an asymptomatic screening measure. It's a bigger market share, it's getting this good test to more people, but is there a better place that we could position this? And then also is using this test for different cancers specifically, something that we want to look into as well. All of these are very reasonable future study outcomes that should be kind of considered in that prospective manner, given a lot of our cohort studies are what we have to draw our information from. Multi-pronged patient education is needed in the future. This is going to have to be addressing SCS, geographic location, areas of isolation, language components and language differences that currently are not necessarily addressed in the patient information on, say, their websites or the patient support programs that I'm aware of as an outsider looking in. In terms of incorporation into employee benefits, is a really interesting concept that was brought up in one of these studies, looking at, is there on-site testing that this could be introduced for? Is this something that we could actually bring to people as a screening test comparatively having people to come to that screening test, a mammogram, a colonoscopy? Is that where this could be a very advantageous technology in terms of an access component? In terms of provider education, providers generally are quite responsive to using MCED in screening programs on survey-based investigations, which is at odds with the fact that many primary care providers are not necessarily comfortable with genetic-based testing, counseling, or disclosure of results. However, those providers in the same studies looked specifically at the concerns that mirror the patient's concerns, largely around cost to patients, is there enough education to patients, do we have insurance coverage for some, or is insurance coverage coming? And if they were to privately pay for a test, would their insurance cover the downstream cost of a positive test if the only indication for that test is positive multi-cancer detection test? And then the regulatory structure is also something that needs to be somewhat ironed out. Pre-market controls versus post-market commitments. Right now, is there current status for requirements for all of the companies where these technologies are being developed to continue to not only once things are to market, but work on how can we improve those technologies, how can we diversify who they're being marketed to, and then can we work on test affordability over time in terms of overall helping the company, but also helping the population as a whole. Who should the data belong to? Should regulation be moved, if we're talking population level screening, away from companies more to centralized labs, more to non-affiliated government bodies that are able to be a bit more of a third party and a little less biased in terms of how these tests should be regulated on a larger scale? And in the health equity assurance that the regulation is mirroring the population that it serves, which, as Dr. Anderson mentioned, in terms of who we are screening, we are screening a very different group of people than may need it. And then reimbursement frameworks we've already somewhat talked about in terms of how we can improve or the things that are needed for insurance programs, HMOs, socialized healthcare systems to actually want to adopt this. We need information, we need other components that would bolster those arguments. And then again, just this socialized healthcare piece as we're kind of moving towards that question of can we bring this technology out of the United States? CAD produced a very nice statement specifically looking at CancerSeek and Gallery in 2022, acknowledging this is a very paradigm-shifting technology. It's very exciting and there's lots of promise. But the three main areas of implementation, not only so much bias but barriers, was we need the real-world studies for us to commit that much cost to the game, more or less. We're addressing specifics around the complex benefits of Harman screening. A multi-cancer early detection test is based on saying that my test for gastric cancer looks for gastric cancer. Not all gastric cancers are the same. Not all lymphomas behave the same. Not all pancreatic cancers behave the same. And so acknowledging that we're oversimplifying cancer and cancer detection and how that cancer responds and how it may move in the future needs to be somewhat more of a nuanced conversation around this testing. And then disruptiveness to the healthcare system, not only in the States, but also in other socialized components. If we are looking at modeling studies that show 50 to 75% increase in cancer diagnosis or cancer signals, is that a finding where these results are essentially laid out evenly throughout a population, or is it in specific groups and specific locations? Do we have enough physicians? Do we have enough allied health? Do we have enough resources to address those cancer diagnoses questions, to investigate and then to follow them up? And the ones that are false positives, that further follow-up component as well, how is that pathway going to be created? And that disruptiveness, even though we want to have disruptive tech in a lot of our discussions, it does have to acknowledge the real-world component of what that could lead to. And these are two very interesting studies, some of which we've kind of already touched on, that from a prospective randomized nature, coming forward will be help with answering a lot of these questions and help move the needle a little bit more in terms of what we can and can't apply. And so lastly, just focusing on ethics. So again, I really liked this phrasing from an editorial that was produced in the Netherlands, looking at what the goal of screening tests should be and what they need to balance against in terms of their acceptability, accessibility, and sustainability as well. So looking at the harms of multi-cancer early detection screening and acknowledging this is somewhat of a surrogate for things like AI-directed changes, technology, different types of genetic-based components. We've talked a lot about financial so far, but if we're looking specifically at physical, again, there are complications to downstream investigations we've already touched on. Even tests with amazing sensitivities and great specificities by all kind of percentage counts have true positives and false positives that get complications. The complications of an early diagnosis of cancer, whether that be a surgery, a chemotherapy, immunotherapy, are very real. So now we're introducing those into the fray as well. So there's a physical toll to these early cancer components as well. Psychologically, whether the test is positive or negative, there can be problems. If we're dealing with a negative signal, that may lead to false reassurance. People are very happy with the idea of a blood-based test that may forego the more invasive, difficult to access testing, but that has better evidence. We could lose uptake in improving cancer screening programs around whether it's the country, the jurisdiction, or the hospital site, which may lead to bottom line issues as well as worse cancer outcomes. Again, we don't know. In terms of cancer signal positive, if we're unable to identify that clear origin site for ctDNA, even though we have different protocols in terms of what a negative test or a positive test that we can't find the source would be, and that's a very long time. It's a lot of psychological stress, time off work, lost work hours, etc. And then identification of indolent cancers that wouldn't change our management anyways. So if we're dealing with a prostate cancer that was never going to be a problem, why do we need to know about it? Does that make things worse for the person? Or is it all information better information? And there's evidence and arguments that it's not. And then identification of tumors with good or effective treatment options. Early detection is great if there is early beneficial treatments and not all of the same cancers behave the same way once found earlier. And one common one is things like brain cancer. One common thing is that, again, if you're identifying or screening people even have a higher risk of primary central nervous system tumors, there's not a lot of recommendations for screening because even if you find it earlier, the outcomes don't change. And so by getting a signal saying, well, you have brain cancer, great, now what do I do with that information? Issues from a health equity standpoint that we haven't touched on. Again, recruitment to clinical trials, historically, high SCS, urban locations, low comorbidities, Caucasian makes these geographically and potentially population level components not necessarily generalizable. The need for an ordering physician. Many people don't have a family doctor. Many people don't have access to a primary care team or essentially in a health desert. And so even if they wanted to pay for this test, they still need a physician on the other end to help and assist with it, and that may in itself be a barrier. And then the need for financial security, which we've talked about as well. Again, if we're looking at America in the sense of 8% of people do not have health insurance, those that do have health insurance, not all of these tests are not covered. So people's willingness to treat threshold, willingness to pay threshold is variable and is different, and again, is ultimately lower than the cost of these current tests as well. So I'll end things on looking at this World Health Organization screening program criteria chart. So this essentially is used when we're looking at kind of how a screening program is working in general, in the sense of is it addressing the things that we want the screening program to do on a population level. Out the gate though, it's hard to really apply this as a multi-cancer to the MCED testing, to a lot of this new tech, in that we just have the test. We're not in isolation. We don't have a screening program built around the tests yet that is a population level. We don't have it integrated into population level screening either. And so this is an exercise more or less than a direct complete evaluation. So if we're looking specifically at objectives of screening at the outset, there's a lot of things that we still need to hammer out, and that what we want to do with this test or this type of technology, how we want to optimize it, and what populations it's supposed to be working in. Acknowledging that cancer is more than just one disease, and that some of the programming can be misleading of how good early detection can be. And then mechanizing to minimizing harms is also one that we want to be acknowledging of and relatively forthcoming with to patients as well. And so in terms of the overall benefits should outweigh the harm, again, it's one of those questions where it's very easy to get caught up in terms of how much better our validation studies and the tests that we can have in terms of advancing science, advancing technology, but acknowledging that it may blur the lines between a screening participant and a research participant from a patient and study perspective. And so I'll end here with a Multi-Cancer Early Detection Consortium statement, which is an organization of UK and USA-based experts on how to address this dynamically changing environment and then advise patients and providers, in that there's insufficient evidence right now for widespread use of this as a population screening context outside of clinical trials, regardless of the health system, and that to establish a future for multi-cancer early detection, we would need rigorous clinical studies that are prospective, randomized, which are ongoing, which is amazing, address health equity issues, which there are many, and then a clear communication to patients and healthcare providers about what this technology is, how it works, how it can be integrated into the system where they live, and how it changes their outcomes, and is there any value in getting screening with this test. Thank you very much.